All right, so welcome to today's lecture. There's going to be three chapters, so I'm not sure if I'm going to do it in two or three different lectures, but I'm going to break it up because I think even though there are cardiovascular related, I'd like to focus on specific areas individually, especially with a lot of these medications and drugs that we're going to be talking about. There will be some overlap. The next lecture that I'll give will be the one on diuretics, the chapter on diuretics. This one right here, as you can see, is obviously on anti-anginal drugs or angina, chest pain. And I will also add in some information that I think is pertinent for all of us to know as healthcare professionals and healthcare providers. So we will be able to be better prepared to face the challenges that as nurses we will have on our day-to-day basis when we're in the hospital, ICU, ED, outpatient, primary setting. Doesn't matter what setting we'll be in, we should be prepared to be able to talk to the underlying problem of what's really going on. When people start to ask why, sometimes they like to have an answer to it, and I'm going to do my best to try to present that information to you. So let's without further ado, start with it. I really have two objectives that I want you to get out of this angina lecture. One, I want you to know the anti-anginal drugs, and those are pretty much very straightforward. We've covered them in a few other classes. Beta blockers, calcium channel blockers are the two main ones. We'll cover a couple other ones, random ones, things that you need to know about them. I'll be specific as to what I expect, but basically know your anti-anginal drugs. What are they for? Any side effects, any contraindications, who should we give it to, who should not receive it? And then know how to talk to your patients if they're getting discharged and tell them, hey, you're going home on a beta blocker. Make sure you take your pulse and make sure your heart rate's above 60. Make sure you take your blood pressure as well before that. Hey, look, you got some nitroglycerin. Make sure that the bottle isn't expired over 3 months, or make sure you teach them how to put it under their tongue sublingually. Remember, they can do it up to 3 times with a 5-minute interval in between. So these are the type of things you need to know about the anti-anginal drugs. Is when you're discharging your patient and they're going home, what do they need to know? So you need to know it in order to be able to, when you give it, be a safe nurse, but also to educate them. That's the first thing. Know your anti-anginal drugs. They're all in this lecture and in your textbook that you can read. The second thing that I will expect you to know is really as a healthcare professional, because that's what a nurse is, registered nurses are healthcare professionals, I really expect you to understand the sort of non-drug approaches for angina. So know how to educate your patient on upstream non-drug approaches, and we'll go into some specifics here, a little bit more than just the 3 inflammatory, oxidative stress, and autoimmunal. We're going to go into a little bit more detail. So I'm giving you a little bit more meat on the bones here to chew with, so I expect you to be able to understand, at least try to explain to your patient what's happening, what angina is, why it's happening, okay? So please be able to answer this question you see on your screen, the one at the bottom in gold. Your patient has angina. They're being discharged home. What do you tell them? They want to know, what's angina? What do I need to know? Obviously, if they're going home on a beta blocker, calcium channel blocker, we need to tell them, sir, or nitroglycerin, right? Side effects, headache with the nitroglycerin, it's a vasodilator, things of that nature we need to be able to tell them. But I want you as a healthcare professional to be able to say a little bit more than just that. Otherwise, we're not doing our job properly, I believe, from a healthcare professional standpoint. Because we wouldn't be using the evidence base and science properly. So let's jump right into it. This is a really good slide that I found to show you that really angina is all about the blood vessel, the artery, and you have coronary artery disease, sometimes we call it coronary heart disease, and what ends up happening is plaque starts to build up, and I'll get to explain this idea and this notion about the plaque being the evil, horrible one that we need to work and attack and treat, because that's the main treatment that we have today with drugs and surgeries to deal with a lot of the plaque. The truth is this plaque buildup is a problem. We do need to be concerned about it because it can start to clot up and clog up the artery to not let blood flow through, and we know that blood has oxygen and nutrients. And if it gets to a point, it can form clots, and those clots can be released and lodge in the brain. They can lodge in the heart. That ends up being a ischemic stroke, or it could be a myocardial infarction, a heart attack. But we'll come back to this plaque shortly. But this is the notion of why angina happens. As less oxygen and nutrients, basically blood, as less blood is able to get through the vessel to certain areas of the heart, it will radiate as a pressure, will feel like a pressure, right? Other things can happen as well. Patients may have signs and symptoms of having erectile dysfunction, fatigue. There may be other signs, but a very clear classic one is that sort of that chest pain. And that's what angina means, chest pain. And really it's basically because of atherosclerosis buildup. And we'll get under the underlying cause of that atherosclerotic closer towards the end. So we do have to change the way we think about coronary artery disease, including angina. And this whole lecture is about angina. So as nurses, if we're task-oriented, right, angina, we must give nitroglycerin, or angina, we got to give them a beta blocker, or angina, we got to give them aspirin, we're missing the boat, right? Because all of these are very important if the patient is going through an acute or a critical condition that we need to reverse as soon and promptly as we possibly can within the acute or critical care setting. Absolutely, we want to think like this, but we need to be going significantly beyond just thinking of angina, nitroglycerin angina, right? Because it's partially correct when the patient is in an emergent situation, we want to give them the meds, try to reverse it as quickly as we can. But medicine overall, healthcare overall is changing rapidly. It's a lot more complex than we think, and it's definitely a lot more complex than simply the one pill for every ill approach. So when you look at this model right here, you're looking at the traditional model, sort of there's risk factors. You end up having CHD or CAD. We use the word CHD and CAD interchangeably. So if you hear somebody say coronary heart disease, it's really coronary artery disease we're talking about, same thing, just for your information. And so once you look at the traditional model, and basically you have hypertension, you get coronary heart disease, now we need to treat it somehow, usually drug surgery. The new model is saying, well, let's look at biomechanical and biochemical insults. Biochemical insults, there's quite a few: toxins, dietary factors, metabolic issues, dead tissue in the body, infections, microbes, H. pylori. A lot of these things can lead to the underlying problem at the endothelial level, which is inflammation, oxidative stress, and we believe as well autoimmunity, which affects the artery as well, which then leads to the coronary artery disease or coronary heart disease. And so these are just, it's important to start to realize that we're really starting to think about not just the major risk factors, which are very important to keep in mind, but that there are some really 3 finite responses within the arterial system that ultimately are leading to the problem that we're having. And we'll get into why inflammation, why oxidative stress, and why autoimmune dysfunction happen in the first place. So please start thinking about coronary artery disease or coronary heart disease, CHD, as an inflammatory disease of the arteries, an oxidative stress state of the arteries, an autoimmune disease that is affecting the arteries. We must start to think in these terms. Now, I want you to take a step back here, and I want you again to think about your settings. We have the furthest downstream setting is critical care. That you can't get more downstream than that. That's you're intubated, you're on drips, we're sustaining your respiratory system, we're sustaining your blood pressure with vasopressors, we're doing a lot of things. That's really downstream, right? Then if you're not in the ICU, but you're still in the hospital, you're in an acute care setting, and in the acute care setting, you're going to be probably not intubated, probably not on a vasopressor, but you may be getting certain drips, titrated drips. You may be getting metoprolol and antidysrhythmic medications and so on and so forth. But then you have to remember that the patient will be being discharged from the acute care one day, be going home. So we have to be aware that when you're discharging that patient, what do we need to understand? Yes, we need to know what the drugs are doing and educate our patient on those drugs, but what else do we need to be able to educate them on? And we need to really start to implant this way of thinking into our mind. So angina pectoris is pecho, comes from the word Spanish pecho, chest, pain, is a problem that again happens at the endothelial, at the artery, within the arteries, at the cellular level, and you want to think of it as when oxygen, or the supply of that oxygen, which carries nutrients, which the blood carries oxygen and nutrients, right, is insufficient. So when the blood is not getting there, the oxygen, the nutrients is not getting there. That means there's not enough supply of this oxygen and nutrients to meet the demands that the heart has to have in order to function as a muscle and to do its job with cardiac output, stroke volume, and all of the rest. And so it starts to ache because there's not enough supply of blood or oxygen or nutrients, right? The heart requires a very large supply of oxygen to meet the demands that are placed upon it. So when there's a mismatch between that large amount of supply of oxygen and nutrients that the heart requires, and now the supply of oxygen and nutrients is not happening because of usually a narrowing of the artery or a full blockage of the artery, then we got a big problem. But initially, before that full blockage happens and they end up having that silent death, or they die suddenly without any other previous warning, then you want to understand that angina pectoris is not necessarily myocardial infarction. You're not having a myocardial infarction, but basically you are, in the sense that in some situations, people will be forewarned with slight chest pressure or chest pain before they get the MI. Now, that said, remember, MI, oftentimes a lot of people won't have angina. And they just have the MI. That doesn't mean that they don't have a lot of the atherosclerosis happening. So ischemia is basically not enough blood to an organ. And the ischemia is what's ultimately happening with atherosclerosis. Of course, it depends on the plaque buildup, how much is built up in the body, in the blood vessel. Will determine the level of ischemia. If there's a complete blockage, well, then absolutely it's not poor blood supply to an organ. There is no blood supply to an organ. If there's 90%, then it's ischemia, and they're only getting 10% of blood to the heart where there needs to get. So ischemic heart disease is what we've been talking about. It's basically what coronary artery disease is. It's basically what atherosclerosis is. It's a poor blood supply to the heart muscle. Then myocardial infarction is when that ischemic heart disease, that atherosclerosis, that coronary artery disease, that angina, maybe with the angina as a symptom, has been happening for a while, and ultimately that part of the heart, that muscle of the heart that has not been receiving the blood, oxygen, and nutrients, dies. It ends up getting necrotic. The tissue dies, is no longer functional, and it cannot be reversed at that point. That's what we call a myocardial infarction. So it's a big difference to understand between angina and myocardial infarction. You do need to know, again, we've covered this, so I'm not going to go over it, the difference between stable and unstable angina and the different names, and Prinz medal as well. But the key thing is the stable angina. Remember, the heart needs this large supply of oxygen and nutrients. If a patient is having sex, walking upstairs, or mowing the lawn, the first thing we always want them to do is stop their activity. If it goes away, we probably will consider it a stable angina. If it doesn't go away, we'll use a nitroglycerin. If that doesn't work, then we'll call 911. But you do need to understand that usually stable angina will go away with rest. So with drug therapy for angina specifically, we need to understand, again, the ratio between the supply and demand of oxygen. Normally, it looks like the top. The supply, the amount of oxygen and nutrients that are available are the normal, and the demand is the normal. The heart is not working overtime. There's no cardiomegaly, there's no diabetes perhaps that the heart is working against with the viscous blood, so on and so forth. But when you get angina, what you end up happening is the demand goes up. So there's a lot more demand, but there's not enough. So the supply of oxygen and nutrients to that heart muscle, that heart tissue, is gone down, and the demand is gone up, and pressure starts to build in the chest. We call it angina. So the goal for angina treatment, whether it's a drug therapy or non-drug therapy, is always going to be to try to increase the supply of oxygen availability at the cellular level for that patient to be able to meet the needs that they have in the heart muscle and the tissue. So take a look at this and let me know what you think. And pretty much I think I just covered this earlier. If a patient's mowing his lawn, hot Saturday afternoon, notice some angina, what should the first action be? Always stop the activity. Sit down or lay down. Yeah, well, he may get the nitroglycerin. Yes, we may need to call 911. Yes, it might be good to go into the house in a cooler environment for sure. Not so sure about the drink of water, at least at this point, but always stop the activity. Stop moving, right? Because by doing that, we're helping the body decrease the demand, right? When you're exercising, your heart has to work harder, so there's a higher demand. By sitting down and doing nothing, your heart is doing less, so there's less demand. Make sense? So here you got it. Even though there's probably about 50 slides that are going to follow this, the drugs for angina are going to be either nitrates or nitrate based, beta blockers, or calcium channel blockers. In a nutshell, this is it right here. So make sure you understand the difference between these three and you know the names of quite a few, okay? Let me take a sip of my tea really quick. All right. So the therapeutic objectives are going to be to minimize the number of attacks and decrease the duration of the angina, improve the capacity of the patient to move further distances and to have as few adverse effects as possible from the angina, and to prevent or delay the worst possible outcome, which is a myocardial infarction. Which is why I add in to this lecture significantly more amount of information than just these three drugs for angina. Because there's a lot of evidence out there that still requires maybe more research, but there's a lot of solid evidence that's going to point to a lot of things we can do to reach these therapeutic objectives. So I'm going to use these therapeutic objectives that come with the drug lecture also as the therapeutic objectives, just like when I go back to this slide here, same thing. This slide here is also the therapeutic objective. It's the benefits, what we're trying to get. We're trying to get more oxygen in, decrease that amount of demand and overwork of the workload of the heart. No different. Doesn't matter if it's a drug or a non-drug treatment, the therapeutic objectives are going to be all the same. Make sense? So nitrates. We can give nitrates in various forms, and the common one in the hospital would be ointment that we put up on the chest. Common one outpatient is usually sublingual. The little star tends to mean that they bypass the liver and the first pass effect. That basically just means that if it does have to go through anywhere of the GI, the stomach, the intestine, the liver, then the bioavailability of the drug is greatly reduced, and then there may not be enough to work. But if you put it under the tongue, it's going to work faster than PO, or oral, por orale. And if you put it into an IV, then it's going to be even quicker than that. So, and again, this has to do with how our body metabolizes the drug. The first pass effect, basically, when given orally, the drug will be reduced before it reaches a systemic level that we want it to reach, which in many cases we probably wouldn't want to be doing if we're in the acute care setting and they're having very high blood pressure or a lot of other issues that may require nitrates or nitroglycerin. We probably want to do it IV first. All right, so we'll go over the patches later. Mechanism of action, I really want you to pay attention to this because I want to see if you can notice something here. The mechanism of action and the drug effects that we're looking for, which goes the same for any non-drug, supplement, vitamin, nutrient, phytochemical, and so forth, same thing, right? We want medications that will cause a vasodilation because they allow the smooth muscles to relax. We want drugs that have a strong or potent dilating effect on the coronary arteries because that allows the heart, it gives the heart time. It rests the heart and it perhaps can allow more blood to get through wherever that plaque obstruction buildup is. We want, and the result is oxygen to the ischemic myocardial tissue. We want oxygen to ultimately get to that tissue. And we want to use for prevention and treatment of angina. Now that last one right there, yes, we'll be talking about nitroglycerins, but we'll go into a few other things. Now, I want you to think of these mechanisms, see if you can get this. So what is this lecture all about? It's about angina. Okay, so let's take a step back and think about the underlying cause that we talked about in our last lecture, that was not pharm, of the underlying causes of patients that have a true angina, right? And we know that it's basically uh, damage or an injury to the arterial lining that ends up leading to a plaque buildup, and that plaque buildup ultimately is the big problem. But really, do any of these mechanisms or drug effects really target the underlying problem? A lot of these are just trying to target the problem of the plaque buildup, of the blockage, of the obstruction to get the blood to go through and carry the oxygen and the nutrients to the area of the heart that's having a ischemic reaction. And so no, the answer is a lot of these really are not triggering the underlying cause, because if you really think about it, and this takes a little bit of time to think about, but if you consider that plaque is not the problem, plaque is not the evil enemy, that it's the injury to the lining of the cell for some reason or another, the weakening of the lining, the damage, the injury, the insult that occurs to the lining of the cell, maybe a crack, maybe a microbleed, ends up building the plaque. The plaque is a reaction to a problem. The plaque is not the problem. The plaque is the body's defense mechanism to patch the blood up. It's like, so plaque is like the Band-Aid. So when we go in with the stent, or we go in with a lot of these drugs, medications, and surgeries, we're just dealing with the Band-Aid. We're dealing with the plaque, but we're not really looking at the underlying plaque problem, which we'll go over into a little bit more in detail. So keep that in mind. Nitrates and nitrites, there's rapid acting, there's long-term acting. One of the big ways to understand the difference between long acting and rapid acting has to do with the route of how it's consumed, right? Are we giving it PO or by mouth? Are we giving it sublingual? Are we giving it IV, right? So nitrates like nitroglycerin, for example, will cause dilation of the large veins, and that reduces the preload, and reducing preload reduces the work of the heart. Now, you guys remember in the previous lecture what preload is. Preload is talking about reducing venous return to the heart. It's reducing it. So when you think about stroke volume, you have to think about preload, afterload, contractility. Remember that from previous lecture? Those are the three factors for stroke volume: preload, afterload, contractility. We want the heart to not work so hard, we reduce the afterload by working on their diabetes, for example, and their hemoglobin, and so on and so forth. The preload is really the amount in the ventricle. The ventricles have to stretch at the end of diastole, and the diastole is the filling or that relaxation phase of the heart. In other words, you want to think of preload as the volume that has filled the ventricles right at that relaxation phase, at that filling phase, okay? And some people will call preload end diastolic volume, but you'll get this in third and fourth semester, not in this second semester. So rapid acting forms are the ones we want to do to treat acute anginal attacks, and those are sublingual and IV, no question about it. Long acting are going to be more to prevent the anginal episodes from happening in the first place, and we sometimes use sublingual for that as well, but we'll cover this in a slide very shortly here. So in this one, for example, look like isordal, which is also known as isosorbide dinitrate, is a long-acting drug. We give it PO when we give it PO, right? A nitroglycerin ointment or a patch, like the transdermal patches that we give of nitroglycerin, they're all longer acting. So we would not want to use, let's say, isordal or isosorbide dinitrate PO for an acute problem. We would not want to use nitroglycerin ointment or a transdermal nitroglycerin patch for a acute problem, angina. We would not want to do that. We'd want to do sublingual, or do we want to do IV, and we want to do it promptly. And we'll go over what promptly means. Now, this is for you guys to answer. Patient with extremely high blood pressure comes in to the emergency room. Physician is going to order some nitroglycerin to manage the blood pressure. What form of nitroglycerin is most appropriate? Sublingual spray, A, transdermal patch, B, oral capsule, C, and IV infusion is D. And as you know, if he's in the ED and we want to get that blood pressure down soon and quick and vasodilate promptly, we're going to go with the fastest route. So that would be IV infusion. Because that's what will have the fastest effect, and then we'll just titrate the dose down to where the patient is responding as we want them to respond, always making sure that we don't kick them into hypotension or the opposite. Now, in this case, for example, let me ask you, do we care about the underlying cause of the disease? Do we care about whether it was a plaque that caused the problem or it was a microvascular rupture in the arterial endothelial lining because of the weakness, because there's not enough copper or vitamin C, and therefore, no, we don't care. We do not care about that. Patient comes in with high BP, we're not going to give them broccoli or CoQ10 or vitamin C. We're going to give them an IV infusion. So I want you to keep this in mind, right? It's not the pharmaceutical world is not against the nutraceutical world by any means. They work together. When it's due to give a pharmaceutical. We will give them IV infusions of nitroglycerin. We don't care at that moment. We want to save their life. But when the patient is going to be going home, we want to tell them the things that they need to know, perhaps from a pharmaceutical. If they're going home on drugs, absolutely we'll educate them on that, but also on a nutraceutical approach to try to boost their oxygen and so on and so forth. The therapeutic goals we talked about earlier. So nitroglycerin is the granddaddy. It's the prototypical, it's the nitrate of all nitrates. It has a large first pass effect with the oral forms. It's used for symptomatic ischemic heart condition, in other words, angina, right? If you're having chest pain or the ischemic heart problem, ischemia is angina. Angina is ischemia. If you hear ischemic heart condition, that's angina. If you hear angina, it's ischemia. You should know that by now. IV form is going to be used for blood pressure control, usually in perioperative, sometimes for heart failure. Watch out with right heart failure. You'll get that in different third, fourth semester. We do use it for ischemic problems, angina. We use it for pulmonary edema that is associated with myocardial infarction because the heart backs up to the lungs, remember that, and we use it for hypertensive emergencies. We don't care about the underlying causes. We don't care about nutraceuticals. We want to give them that IV. We want to save their life first. And then we'll talk to them about what they need to know in their lifestyle prevention. So further nitrates, the biggest, I wouldn't call headache an adverse effect, even though it is. It's a side effect, and we need to tell our patients when we give it to them, unless they've built a level of tolerance, hey, look, this is going to open up it's going to vasodilate the vessels in your brain, and that's going to cause significant. It's going to drop that vascular system, and it's going to create a headache, and that'll diminish over time. Let them know that it is expected. It's not something we want to try to prevent. We're giving them nitroglycerin to prevent a lot worse problem than having a headache. So tell the patient that. Just remind them that, hey, headache is actually, even though it's very uncomfortable, we understand that, but remember, think of it as a good thing because we're actually saving time for your muscle to recuperate, for your heart to rest, and so on and so forth. And we'll talk a little bit about, we have to watch out with postural hypotension. Once you do have that vasodilation, they can get up and have fall risks. So we have to usually bed rest or make sure that they're able to call. Reflex tachycardia just means the body with the baroreceptors is going to notice that there's a drop when it vasodilates, that the vascular system sort of collapses in a sense. Think about vasodilation, right? That's why the headache happens. The body could sense that vasodilation or that sort of sudden vascular change in vascular space and room because of the vasodilation, that the body says, wow, I need to compensate for that sudden drop. So let me start getting my heart going faster. So sometimes there will be a reflex tachycardia. And intolerance, there's a slide on that shortly, so we'll talk about that when we get there. Patients walking his dog, develops angina, sat down, still has that angina, even though sitting down. What would we call that? Stable or unstable? Thank you. Unstable. When should he call 911? Well, let's think about this. We know that with sublingual nitroglycerin, the medication, you always want to take it right at the first sign of a chest pain. Don't delay it. Take it. Should sit down. Obviously, always stop, sit down, right? And we are going to do it 3 times, no more than 3 times, right? And especially if it's not relieved, we'll wait 5 minutes in between each time, right? And what we're starting to say right now used to be, I believe, years ago, where we would suggest them to take all three. Take nitroglycerin sublingual, wait 5 minutes, take it again, wait 5 minutes, take it again. That's changed. So you should be able to detect which is the proper answer here. If there's chest pain or discomfort and it's not relieved within the 5 minutes of the first dose, call 911, take the second dose, and if the ambulance hasn't arrived, take the third dose, but again, 5 minutes in between each. Usually ambulances are supposed to arrive within 7 minutes, so the patient would hopefully be getting either the second or the third nitroglycerin sublingual on the ambulance before that. So you have the answer to that question right there. Tolerance is when the patient has been on it for a long time, and it's really not a good thing. So it's a really good idea for us nurses to remember that we must every night remove any transdermal patch or ointment that we may have placed on the patient's chest for 8 hours at night, and then we'll reapply the patch or the ointment in the morning, because we want to prevent that tolerance from happening, because ultimately, if they do build tolerance, nitroglycerin won't work as well, and it can have other side effects. But the main one is we want to allow their body to go for short periods of time, usually throughout the night, without the nitroglycerin, so that when we do give it in the morning, it's able to function properly, and we're not constantly keeping the patient in a vasodilated mode. Contraindications. So we're still on nitroglycerin. Well, if they have an allergy, don't give it to them. If they have severe anemia, probably not, for multiple reasons related to H&H. Closed angle glaucoma, we don't want to give it to them because of the pressure changes in the eye. If they're hypotensive or bradycardic even, we may not want to give it, especially hypotensive. Any severe head injury, because if there's a bleed, in some head injuries, we want to maintain some pressure, and giving them a nitroglycerin is only going to reduce the pressure more, which could lead them to a lot of problems, especially if they have certain types of hemorrhagic problems as well. And if they're on sildenafil, Viagra, Cialis, any of those erectile dysfunction drugs, do not give nitroglycerin. We talked about this in another lecture. I'm not going to go over the story about that nurse telling her to give her husband both of them at the same time. Obviously, she wanted to kill him. You had that story in a previous. So we're changing here to isosorbide dinitrate, isordyl, right? It's an organic nitrate. It's available in rapid acting when it's sublingual. It also is an immediate release when it's a tablet, and long acting oral dosage as well. That said, though, we always go with nitroglycerin, sublingual or IV as the acute. We don't tend to use this that much in an acute, although in some instances the doctors will decide to do that. I just threw this in there for the fun of it. Talking about nitrates, right? If you want to consume a high amount of foods that are able to work on your nitric oxide, which is a gas in your body, which helps with the vasodilation, eat a lot of the very high nitrate content: celery, cress, chervil, lettuce, red beetroot, spinach, rocket, rucola. These are all good things. All of these here are good. Some just have less than others. Some have more than others. Cabbage is really known to be very high, and fennel as well, endive, leeks, parsley. And what are all of these? What's one common thing they all have? They have in common? Sulfates, right? All right, so continuing back to nitroglycerin. It's a prototypical nitrate. It's the most important drug used with ischemia, angina, period. Nitroglycerin, right? And again, the routes are the same ones. We already talked about that. PO, sublingual, spray under the tongue as well, IV, topical. Some doctors and outpatients, instead of giving sublingual, will give a spray. And there may be some benefits about that, because nitroglycerin, you have to understand one thing with nitroglycerin: when the patients put it under the tongue, if they complain about a stinging under their tongue, that's a good sign. It means that pill is still powerful, strong, potent, still has the nitrate within it. If Usually those little tiny vials, when you give it to the patient, make sure that you don't touch it with your hands. You put it into the little cap, one, and you put it on the patient's tongue. Nobody should be touching it with their hand because it can go through the skin. And so the problem with having those little vials, you have to store them properly, and they can't be open for more than 3 months. So if they're taking one that's been open for 2.5 months, 4 months, 5 months, they're going to put it under their tongue and not feel that stinging. The lack of stinging means probably not working that much. And I added in this image here to show you what nitroglycerin does. It takes a normal vessel, it dilates it, it opens it up, and allows those nutrients, including glucose, to go through. And all of that will decrease blood pressure, and it helps with the removal of cellular waste product as well. This is just another image that I added in there to show you that that with vasodilation, it's not only the blood flow that's increased, but also the permeability of the blood vessels also increase more. And that is a good thing because the sympathetic system helps trigger a little bit of the glucose production, and we want that glucose production to get to the heart, to the tissue, to the muscles. And with vasodilation, the permeability opens up, then these nutrients, glucose including, can get to the tissues and to the muscles as we want them to get there. All right, changing from nitroglycerin and the isoryl. We're now in the beta blockers. I'm not going to go over a lot of this because we've already had this. They're the main treatment in a lot of cardiovascular diseases. Angina is one of them, myocardial infarction, hypertension, and dysrhythmias as well. So yes, we do use beta blockers for angina. Which are the typical anti-anginal beta blockers that are used? Atenolol, metoprolol, propranolol, and nadolol. And we'll go into this shortly. Just remember what they are. How do they work? What's the mechanism of action, right? Well, they block the beta-1 receptors. When you hear beta-1 or beta-2, beta-1, we only have one heart, think heart. Beta-2, we have 2 lungs, think lungs. So keep that in the back of your mind. We'll cover that shortly. But beta blockers block beta-1 receptors of the heart. They're adrenergic. Adrenergic is a sympathetic response. And sympathetic is a fight or flight. So this is sort of trying to do the opposite of the adrenergic. It's trying to slow down the sympathetic by blocking the beta-1 receptors, which is activating the sort of, in a sense, activating the opposite, the parasympathetic. But basically what it's doing is it's trying to slow the heart down, slow and lower the blood pressure. It can therefore decrease the heart rate, which will increase, it'll decrease the oxygen demand, but increase the oxygen delivery to the heart, right? And it will decrease myocardial contractility, helping conserve energy, which is essentially what decreasing demand means. So if you decrease the heart rate is working less. Now, so keep that in mind. We'll go to the, so in a lot of times after patients have had a heart attack, myocardial infarction, a lot of the catecholamines from the sympathetic system are throughout the body. They can cause a lot of imbalance and lead to a lot of the dysrhythmias. So beta blockers can help work to ameliorate a lot of these catecholamines in the blood to deal with them. They basically block the effects of catecholamines. So it has been shown that after a heart attack, they have been proven to help significantly in those catecholamines. Now, hawthorn berry, which is a tree native to Europe, a lot of traditional healers use the leaves, the flowers, berries. They're one of the first cardiotonics out there. And both beta blockers and hawthorn are useful for hypertension. The one big difference, beta blockers won't have a diuretic action. They have to treat the hypertension, but hawthorn is both a diuretic as well as it serves similarly to how the beta blocker does. That has to do a lot with the flavonoids and enzymes and whatnot. So just thought I would throw that in there for you. What do we use beta blocker for? What are the indications? Well, we use it for what we just talked about, angina, hypertension, certain dysrhythmias, to protect the heart after patient has had an MI, and sometimes even for migraines, tremors, stage fright. Because remember, stage fright. How does a beta blocker help with stage fright? Okay, well, if we know that a beta blocker, beta ones especially, are working on the adrenergic system by lowering the sympathetic response. If the sympathetic is fight or flight, and we lower that adrenergic sympathetic response, then they're going to be a lot more calm and relaxed. They may be more prone to go onto the stage. So wonderful. I would rather take a Hawthorne than a beta blocker, if you ask me, because as I'll show you, they're not without their side effects that aren't that good. Why would you not, who would you not want to give a beta blocker to? What are the contraindications? Why would you not, or never, or ever, you're a nurse, you're getting ready to give it to a patient, you need to know when not to give it. So if a patient has systolic heart failure, don't give it. If there's a lot of conduction disturbances in the heart, certain fibrillations, certain types of tachycardia, also, especially with the beta 2 lungs, we want to be careful. If they have asthma or COPD, don't give them, okay, one of these beta blockers. Diabetes mellitus is an interesting one because it can mask low sugars, hypoglycemia-induced tachycardia. Remember, we know that beta blocker. When you go to give a beta blocker, what's the nursing action we need to do? We need to check their blood pressure. We need to check their heart rate. Their heart rate has to be above the lowest rate, 60. If it's lower than that, we need to contact the doctor or see if there's an order to give heart rate above 55 or something of that nature. But what's interesting is that because the beta blocker, so yes, we want to make sure their heart rate's above 60 before we give them a beta blocker. Why? Because we know it lowers the heart rate. Well, if a beta blocker lowers the heart rate and a patient who has diabetes, if they're really having low sugars, which can trigger a response of tachycardia, the beta blocker could mask one of that symptom. So we have to be a little bit careful with patients in diabetes. And then peripheral vascular disease, it can further compromise cerebral or peripheral blood flow as well. So these are the people we wouldn't give it to. I'll let you look at this, but this is really for beta blockers. In different systems, they have different effects. In the cardiovascular system, bradycardia, hypotension can cause AV block, which is why we wouldn't want to give somebody who has certain types of block, second, maybe even a third, especially a third. Be careful. Metabolically, it can cause hyper or hypoglycemia. It can cause hyperlipidemia. It can neurologically cause dizziness, fatigue, depression, lethargy, can put them at risk for fall, right? Impotence, wheezing, dyspnea. So these are the drugs that they want you to take for a stage fright. Go ahead if that's what you want. Absolutely. If it helps you, why not? Hawthorne berry has very similar effects to beta blocker. Why not try that? Okay, we're moving into one form of the beta blocker, atenolol or tenormin. And tenormin it's a beta 1 adrenergic receptor blocker. We give it for prophylactic treatment. This is given so that patients won't get that chest pain. And we use atenolol after an MI has happened because it decreases mortality. But notice that, right? So let's talk to our patients about nutrients as well that can repair the damage or insults to the arteries where the arteries have received these insults, right? We'll talk about that shortly. And maybe mention, because why wait till after they have a heart attack? We're going to have to learn what we need to tell them to, okay, they're going to be going home. You already had an MI. They could have a second one or a third one. Some people have had up to 11 stents. I've met people with up to 11 stents, my friends. So if we're not talking to them about, hey, when you're going home, I want to make sure I don't see you here again for another heart attack and another stent. Let me talk to you about how to do that. And that's one big thing that we'll go over here shortly. Metoprolol or Lopressor is again beta 1. We give it for the prophylactic angina, same as atenolol. Give it to after an MI to treat the angina. We can give it oral or parenteral injectable, commonly given in the hospital, both oral and IV. And we give it a lot for hypertension. We just have to watch out A lot of times when you give metoprolol, if the patient is having really high blood pressure, sick sinus syndrome, some complication where they may have a heart rate of 40, but a blood pressure of 170, what are we going to do? We probably wouldn't be giving metoprolol. We probably would give hydralazine, but hydralazine is not even part of this lecture, but just remember metoprolol we wouldn't want to give it with the low heart rate. Keep that in mind. We'd want to give a different type of medication. So what do you guys think? A patient who has an MI taking a beta blocker, what's the main benefit of a beta blocker? Like Hawthorne, for example, right? For this patient, what do you guys think, right? So what do we want to try to do if they're having ischemic heart disease? We want to reduce myocardial oxygen demand. Remember the goal of therapy, reduce the demand, increase the supply, right? Allow the coronary arteries time to fill with oxygen and nutrient-rich blood. How do we do that? We slow the heart rate. We slow the heart rate. And by slowing the heart rate, and let me repeat it, in patients that have angina or ischemic heart disease, we will reduce the myocardial oxygen demand, allow the coronary arteries to fill with oxygen and nutrient-rich blood, right? And beta blockers also, as we talked about earlier, they can block the irritating effects of circulating catecholamines in the heart. So now we're changing here. Let me take a quick sip here. We're going into calcium. Calcium channel blockers. So remember, these are the calcium channel blockers you need to know. There's only three categories, people. Three categories. Calcium channel blocker is one of them. These are the medications that fall under that category: amlodipine, diltiazem, nicardipine, nifedipine, verapamil. What's the mechanism of action of these? They vasodilate the coronary artery. They cause our peripheral vasodilation, and they decrease the workload of the heart. If they're vasodilating peripherally as well as the main artery, then the heart is working against less resistance. That's what decreasing systemic vascular resistance means. They work by reducing the workload of the heart because they vasodilate. And the result that we want to get from them, or the action that we want, is they decrease the demand for oxygen, right? And they're also given for dysrhythmias or arrhythmias. They depress the automaticity of the conduction that through the sinoatrial and the AV nodes, and we'll go over that. We have one of the lectures that I haven't prepared yet is on antidysrhythmic medications, and we're going to have quite a bit of talk about the SA node and whatnot. Not here. Why do we give the calcium channel blockers? What are the indications? Who should be receiving it? Again, high angina, hypertension, SVTs, supraventricular tachycardia, coronary artery spasms. The Prinzmetal angina that's the third type. We have stable, unstable, and Prinzmetal. Calcium channel blockers are given for Prinzmetal. We give it to people who have short-term management of AFib and flutter. We give it sometimes for migraine headaches. Again, a lot of that Raynaud's disease, which is a peripheral problem related with smoking and cold blue fingers, so forth, and we give nimodipine especially for artery spasms in the brain that may be associated with aneurysm rupture. And again, aneurysm rupture. God, did I put that into the lecture here? I hope I did. Aneurysm rupture. There was a case back in the 1970s or something where, like, I forget what percentage, 50%, 60% of the turkeys in the nation were all having ruptured aneurysms that were popping and bursting. And an aneurysm is a little bubble that forms on the arterial lining of the wall of the blood vessel, the artery. And so why does that bubble form in the first place? Well, the artery is weak, doesn't have enough collagen, doesn't have enough elastin, and if that ends up rupturing, and one doctor, Dr. Joel Wallach, he ended up when he was a veterinarian and dealing with this problem, he found out that they were all deficient in copper. All right. So who do we not give calcium channel blockers? What are the contraindications? If they have an allergy, don't give it. If they're having an acute MI, we will not give it. We do not give calcium channels for an acute MI. Just remember that. We do not give them for a second or third degree AV block. If they have a pacemaker, they will. Again, that's up to the doctor to make that determination. And if they have low blood pressure, do not give calcium channel blockers. You just need to know that. Adverse effects, well, there's some limited use of it, and we'll go over that shortly. The primarily adverse effect has to do with the overexpression of what we're trying to get in the first place. So if we're trying to lower their blood pressure or vasodilate, well, giving it to them is going to cause too much vasodilation perhaps, or too much of a lowering of a blood pressure. That's what overexpression of their therapeutic effects mean. And it can cause hypotension and reflex tachycardia, palpitations, bradycardia as well, constipation, nausea, dyspnea, other side effects. So take chocolate. Dark chocolate is nature's best calcium channel blocker. Yes, just don't consume it with too much sugar. All right. Diltiazem, cardizem, very commonly used in the hospital. You really need to be very familiar with this drug. It's extremely effective for angina pectoris or chest pain that's happening due to coronary insufficiency, even with hypertension. We use it sometimes for AFib, A-flutter, and for paroxysmal supraventricular tachycardia as well. It is a wonderful antidysrhythmic, very good medication for that purpose. I've seen it work multiple times, and it's wonderful. Amlodipine is a different type. We give it also for similar reasons, angina, hypertension. We only give this oral use. A lot of patients will be taking it from home, or they take it at home. Now, there's a couple of anti-anginal drugs like Ranexa. We don't really know what they do. We know that we have to watch out with the QT interval and the electrocardiogram. And we usually use Ranexa for patients who have failed all of the other ones that we talked about. Who should not be getting Ranexa? Well, if they have any type of heart conduction problem, like a known QT prolongation, liver problem, or those who are taking QT prolonging drugs like hydroxychloroquine or other natures of that, sotalol, for example. If there's a known drug interaction, obviously we wouldn't give it. So just keep in mind that Ranexa is one of the last choices, and we do want to be careful with it because it has problems. So as nurses, what do we need to know? Well, we need to, before we administer anything, we need to get a history, and we need to know if there's any contraindications before we give it. You now know what the contraindications are for these three main categories and the Ranexa as well, an add-on miscellaneous drug. We need to obtain a baseline vital signs, look at their respiratory pattern, look at their heart rate, do a full set of vitals before we give any of these medications. If you're not doing that, shame on you, do it. Get in the habit of doing it. Every time. If you took your blood pressure already at 8:30 before 9 o'clock meds, and you're going in and you're super busy, and you're giving a metoprolol or a calcium channel blocker at 9, number one, don't go off of an old blood pressure or heart rate. Take it 5 minutes, take it right there when you're getting at the bedside, getting ready to give the pill to the patient, and then just assess for the drug interactions. Also, I would add assess for the effectiveness of the drug that you're giving as well, and educate them on things like headache, if it's a nitroglycerin, things of that nature. Patients should not be taking any medications, including over-the-counter medications, without checking in with their physicians. Now, I believe that's 100% true, but I think that if you're talking to a physician who may not be familiar with using amino acids as a treatment, or using nutraceuticals as a treatment for your patient, then I would say obviously go to the physician to get a good idea for the drugs they're using, but don't please expect them to know a lot of the nutraceuticals, because that's not what an allopathic medical doctor was trained to do. That's slowly starting to change as new doctors are coming out. They're a lot more aware and willing to check things like vitamin D, B12, and things of that nature, but this is slowly sipping in. So what I always like to say, if you yourself have a doctor who doesn't understand a lot of these nutraceutical or the upstream approach, and they're just going to start giving you Ranexa or something, or wait till you have to need Ranexa before telling you about a lot of the other stuff that I will talk to you about here in this lecture, fire that doctor, get another doctor. I keep saying this. I will never tire to say that. Fire the doctor. If the doctor doesn't know how to use it, find one that is up to date with treatments that are less invasive. And I think if most of you and a lot of people start finding doctors, eventually there won't be doctors out there that work like that, because physicians should be aware of both type of treatments, drug and non-drug. But unfortunately, they're very, very familiar with the drug. It doesn't work so much for the non-drug treatments. But as nurses and Florence Nightingale, hey, we can talk about diet and vitamin C and nutrients and air and oxygenation and exercise and Hawthorne all day long. That's what Florence Nightingale was significantly about. Be careful with having your patient take caffeine in many of these situations, because caffeine can increase palpitations. Caffeine can, in some situations, increase adrenergic response. It can release sympathetic response as well. Tell the patients that if they're on any of these medications, the three main categories we talked about here, right? Nitrates, nitroglycerin, or beta blockers, or calcium channel blockers. Watch out with blurred vision, persistent headache that doesn't go away, dry mouth, edema, fainting episodes. Weight gain is a really big one that we want to watch out. That's a severe, I think that's beta blockers right there. If you have a patient that gained, 2 pounds in a day or 5 pounds in a week, big problem. They probably need to be reconsidering what meds they're on, contacting their doctor as well. Watch out with people who have heart rate below 60, and watch out with shortness of breath and people with the beta 2 especially, asthmatics and COPD. Alcohol can be, or spending time in hot baths, whirlpools, hot tubs, saunas can vasodilate and lead to more hypotension, so be careful with that. Teach patients to change position slowly, to go from a laying to a sitting position, to sit for a good 2 to 5 minutes. Some people say 1 to 2. I always tell them sit longer. Give that blood time to get to the brain before they actually stand up. And then encourage your patient to keep track of when they had their chest pain, their anginal, and what they were doing at the time. Sometimes they'll put them on monitors and they'll have to make a note of what they were doing. I was walking up the stairs, I was mowing the lawn, and it happened. I was doing nothing, watching TV, and it happened. I was having sex, and it happened. You see the point. So it's a good idea to sort of notice when it happened, what were they doing, if anything, at the time of when the angina happened. Do you remember, talk to them about proper sublingual nitroglycerin. We've been going over that throughout this whole lecture. Tell them to never chew or swallow the sublingual. Don't touch it with their hands. Put it in from the vial into the cap into the mouth, only one. And that burning sensation that they're going to feel underneath the tongue means the drug is still working. It's still potent. It's still strong. That's a good thing. So you can tell them that together with the headache, both things are expected. Although not everybody gets that burning sensation, so don't go looking for it. But if they do get it, they're more sensitive in their taste buds, then it's normal. But don't go looking for it. Not everybody will complain about that, especially when they're having chest pain. That's what they're focused on. Tell patients to keep a fresh supply. That means 3 months or less. So when they open the bottle, to date it. Tell them that it should be stored in an airtight, dark glass bottle with a metal cap and no cotton filler. They already come like that. You'll be familiar with what they are, and don't touch it. Don't touch it with your hands. Then talk to them about the nitrate topical, the ointments or the transdermal. Rotate site. Don't always remember to remove the old patch or the old ointment before you put a new one on. You don't want to double dose them, my friends. Don't do that. Removing a patch before you put nitroglycerin on is a medication safety check that we have to do, because if you put a second patch on, ointment or a transdermal patch of nitroglycerin, without taking that first, the one they already have on off, you're double dosing there in a very serious sense. So don't do that. And then to reduce tolerance, remember we're going to tell the patients to remove any of the topical, that's the ointment or the patch, at bedtime, and put a new one on in the morning to allow for a nitrate-free period of time. Tell them to take it the first time they have chest pain, take it. Remember, they're going to take it up to 3 times, 5 minutes in between, right? And tell them to monitor acute exacerbations of chest pain. And when they're on an IV nitroglycerin, we're going to have them on the monitor probably and just check their vital signs frequently. Q10, Q15 minutes, depending on the floor you're on. If they still have chest pain, tell them they should lie down or stop doing their activities, and tell them to be careful with hypotension because they could end up falling. If this is key right here. If the anginal pain occurs, tell them first thing to do is stop activity and take one of the sublingual nitroglycerin. If the first sublingual nitroglycerin under the tongue doesn't work within that 5-minute period of time, call 911, take a second tablet. If there's no relief, then take a third. Do not try to drive to the hospital, just call 911. That's what we need to be telling them to do. When you give nitroglycerin through the IV, make sure you give it with the right tubing, people. Don't use PVC tubings or bags. The bags will come from the pharmacy. We need to, on the floor, get the tubing. Make sure you get a non-PVC tubing, because it'll break down the tubing and it'll affect the medication itself. Not good for us to be putting any of that PVC into our patients. If you see any color, blue, green, dark red, in the solution we're going to give IV, don't give it. Discard it, contact pharmacy, get another one. And then follow the manufacturer instructions for the IV. Okay, beta blockers. So remember, heartbeat 60 or above. Below that, be careful. Tell them about dizziness or fainting. Fall risk, people. Fall risk, beta blocker. Inform the patients they should never stop this abruptly, and I believe that has to do with a rebound hypertension. They could go into any type of antihypertensives you don't want to stop suddenly. Inform the patients that are on these medications that they're on this for the long-term prevention of angina, not for immediate relief. I want to make my little comment about this. Really, long-term prevention of angina is lifestyle changes and doing a lot of things that are not drug related. Absolutely. What this really means here is that we need to tell them that beta blockers are not given for immediate relief. They're not what we're going to, if you're having chest pain, it's nitroglycerin, it's not a beta blocker. Okay? So it's not given for an emergent situation. That's what we mean by long-term prevention. We give that when you're out of the hospital on a daily basis to hopefully prevent you from getting that angina in the first place. So from an upstream approach, there are many, many other and better long-term prevention methods that we will be discussing very shortly. Nursing implications for calcium channel blockers, constipation, so water and high fiber fluids, in general, with anti-anginal drugs, always monitor for allergic reactions, headache, lightheadedness, hypotension, dizziness before you give it. Tell them that they'll get it. They may get it after you give it, but make sure you monitor before you give it as well. And then we monitor for the effects of it. So did it help relieve the chest pain? Did it help drop the blood pressure? Did it do both? Did it do one of them more than what we want? Did it drop the blood pressure beyond what we want? We need to be careful with all of this. So answer this. The nurse is preparing to educate a group of patients on management of angina. You should be able to talk to them now about the three categories, together with that miscellaneous Renexa, but you should talk about the nitrates, you should talk about the beta blockers, you should talk about calcium channel blockers. You should be able to tell them what they need to know, right? So the answer to the question is, which drug groups are the most often used to treat patients with angina? We're talking about drugs specifically. Well, the nitrates and nitrites, the beta blockers, and the calcium channel blockers. I just gave you the answer. But my question to you is that all science and evidence can provide us as to what we can educate our group of patients to have for proper management of angina? I think not. We'll talk about that shortly. So patient asks you to tell her more about the new drug, Renexa, that she's taking. What response would you want them to know? And remember, we don't know what the mechanism is. So the answer is, we don't know how Renexa works. But here you go. Let's take it. Really, Renexa is used, in the most part, used for after treatment with other anti-anginals have not been affected. We give it only orally. Remember what I said earlier. And anybody with liver failure, no Renexa. Liver failure, no Renexa. Liver failure, no Renexa. So you would never start a patient on Renexa if they haven't tried nitrates, beta blocker, or calcium channel blocker. Renexa is the last choice. We don't know how it works. Go ahead and take it, but monitor the liver. Don't give it if the liver has a problem. What information are we, you, the nurse? You're the nurse. You're the healthcare professional. You're getting ready to teach a patient about beta 2 lungs, blocking drugs for the treatment of angina, right? Well, remember, one of the serious adverse effects of beta 2 blocking agents, is really, really important. Can you detect which one it is? We talked about it. Weight gain can indicate a serious effect of that. So if they've gained that weight, be careful. They may need to be reconsidered on what drugs they're taking. Patient asks how to apply transdermal nitroglycerin. What are we going to tell them? Well, we want to make sure that we remember what we talked about earlier. We rotate the sites. We use areas that are residual free so we don't repeat the site. Try to do it on somebody who doesn't have a lot of hair, otherwise absorption won't happen. And the old transdermal patch should be completely removed before a new one is put on. So you can see which one. In this case, we don't apply Vaseline. We don't keep the patch on for a full day. No, 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 no. You already know that. We don't apply the transdermal over the area where the chest is, or always apply. You can put it up slightly above in the upper area of the left chest, but apply the patch to the hairless area of the body is the answer. So C. All right, this is where I like to kick right on in. So let me give you some food for thought right here. So you already know the mechanisms, the therapeutic goals of what all of these drugs can do. But do all these drugs, or are these drugs all that our science and evidence-based medicine can provide us for educating our patients on angina? Remember that I asked you at the beginning, the first slide right off the bat. I'm going to take a sip of my tea here, but you should be able to think for a quick second before I get to the next slide. What am I going to tell my patients about angina? What do I need to tell them? What do they need to know before they go home? How can we prevent them from getting it again? All right, let's jump right on in. Well, remember I talked about plaque as not being the big enemy. I think a lot of times where even a lot of healthcare professionals, not in your case, you guys are going to be very aware of this because you'll know it now. And plaque, yes, plaque is the problem. Plaque is a problem because it obstructs the artery. But why? The question that should be asked, let's always try to go for the underlying cause of the problem. And how do we get there? Why did the plaque, or why does the plaque appear? Why does the plaque pop up? Why? Why is there plaque? Well, usually the plaque as a band-aid is trying to repair an injury, an insult that happened to a weak vessel. So we want to talk to our patients about what can we do to strengthen the vessel? That's one thing, strengthen that vessel, right? Then we can do things to prevent the plaque, but we'll get into that. So look at the top. When you work in the downstream setting for long enough, acute care, critical care, you end up focusing on the two things on the right: atherosclerosis angina, atherosclerosis angina, atherosclerosis angina. And generally, we do angiography, we do cardiac catheterization as radially, ephemerally. We give them the drugs, we give them drips, we give them all kinds of stuff. We send them back out. We never talk about their arterial injury. What's happening to the arterial injury? So this food for thought is really looking not so much anymore at the atherosclerosis, which is the buildup of the plaque, or angina, which we just talked about from a drug perspective, especially with the three categories plus the miscellaneous Renexa. But let's read what it says right there. The warning signs of clogged arteries, and this is all true coming from the Physicians Committee for Responsible Medicine. Well, if you're having low back pain, chest pain, erectile dysfunction, painful, numb, cold hands or feet, fatigue or dizziness, even stroke, these are all signs of clogged arteries. And up at the top it says right there, when cholesterol particles build up in the arteries, that's what atherosclerosis is. Actually, cholesterol is actually wrong. It's not cholesterol. It's LPA, which sticks out and ultimately starts creating the plaque. They form plaques that narrow the path for the blood flow. Narrowed arteries strike all areas of the body and can lead to pain, discomfort, ultimately result in a heart attack. So this is great, but nowhere does it really talk about arterial injury. So I'll talk about that shortly. I wanted to throw in, this is one of my favorite all-time websites, Linus Pauling Institute within the Oregon State University, and I just copied this little right here, Angina pectoris. And a really wonderful article. I just took a quick snapshot to show you what evidence-based research is out there and available to us. And they say that the summary of angina pectoris, remember, we're at this point still not talking MI, it's pre-MI for the most part. So summary, angina pectoris occurs when the heart tissue needs more blood, right? That's the supply, than it's getting. Well, we know that L-carnitine, quite a few other amino acids as well, and coenzyme 10, which is an enzyme, have important roles in energy utilization inside our cells. So supplementation with these nutrients under medical supervision. Again, let me take a stop here. Under medical supervision by someone who knows how to supervise carnitine, coenzyme 10, who works and has been working with these things. Not somebody who doesn't use them and definitely not somebody who poo-poos it. Definitely. Those are the guys or the girls, fire them. Get another one. So all of these might improve exercise tolerance and reduce the signs of ischemia in patients with stable angina. Poof. Okay, so I just gave you two pieces of information that we can give our patients right here. It's evidence-based. It's out there. It's diet. We can get in our foods. We can give it to the patients. But there's a little more to the story here. So that's just, so why did all the plaque buildup should always be the question. Why did all the plaque build up? There you have it. That's the answer. Everything I've been talking about right here. This is the answer. Blood vessels are weak. They lose elasticity. They lose elastin. They lose collagen. They have microvascular ruptures. They have larger ruptures. Hemorrhagic stroke is a bigger rupture. But microvascular ruptures happening all the time are occurring because of injury to the inside of that cell, which tend to be the inflammation, oxidation, oxidative stress, autoimmune, the three finite causes, but ultimately you have a weak vessel, and that weak vessel causes a rupture. Some of them are big, some of them are smaller, and then the plaque has to start to patch that up. So again, the plaque is the body's natural adaptive response, not the problem. It's the adaptive response. I hope you guys are getting that. Linus Pauling, I can't tell you how much. I mean, boy, I tell you, he's poo-pooed. They have him on Quack Watch. They have him on, oh boy, they have every gun and arrow pointing at this man. But he by the way, in 1989, he was eminent American scientist, two-time Nobel Prize winner. I bet you a lot of people regret giving him not one, but two-time Nobel Prize winners. Anyways, he did win two Nobel Prizes, and he found a pretty big breakthrough that is being completely ignored. I'm not ignoring it. Many doctors are not ignoring it. Many doctors weren't educated about it. Many nurse practitioners are still to this day not educated about it, right? So he talked about a unified theory of human cardiovascular disease. And let's look at what Linus Pauling had to say. This is really important. He announced that the deposits of plaque that we see in atherosclerosis are not the cause of heart disease, are not the cause of CHD, not the cause of CAD, not the cause of angina. Plaque is not the cause, but they're actually the result of our bodies trying to repair the damage, which was caused by what? Long-term nutrient deficiency, most notably vitamin C deficiency. Let's keep that in mind. Is this true? Well, we know that cardiovascular disease, for the most part, in animals that are able to produce endogenously within their own body vitamin C, they don't tend to have a lot of heart problems, right? They produce a lot of significant amount of vitamin C. Second point is only animals that produce LPA, which is what really is the little thread that sticks out that the plaques end up attaching to, are not cholesterol, it's LPA. So when you go get your cholesterol done, get an advanced panel that looks at particle size and for LPA. So only animals that produce LPA are those which, like us, mankind, we do not produce vitamin C endogenously. We do not produce vitamin C endogenously. Human beings do not produce vitamin C within our own body, just like apes and guinea pigs, right? So those animals, guinea pigs, apes, humans that don't produce vitamin C are also animals that produce the LPA, which ultimately are what cause that trigger. So when arteries are becoming weak and begin to rupture, think about this. The body is going to respond by gluing the damaged or the injured areas together with the LPA to prevent a slow death from internal bleeding. Did you catch that? From internal bleeding. Scurvy, right? Vitamin C deficiency, bleeding of the gums. It's an internal type of bleeding. Has very much to do with that LPA that attracts a lot of the plaque that ends up trying to glue the damaged area together. So keep that in mind. So ascorbic acid, vitamin C. There's a lot of research, and we know we don't make it. This is a repeat of what we just were talking about on the previous slide, so I'll let you go over that if you wanted to pause. This is one of the most important things that I want to bring your attention to. Collagen is the protein that forms the connective tissue fibers, such as skin, ligaments, cartilage, bones, teeth. Collagen acts also as an intracellular glue that gives support. Let me show you what I underlined. Gives support and shape and bulk to blood vessels. Also, the bones and organs, heart, kidneys, liver, collagen fiber keep bones and blood vessels strong. And blood vessels strong, I forgot to underline that. Again, and blood vessels strong help to anchor our teeth to our gums. Collagen is also required for the repair of blood vessel. And what do we need to create collagen? Vitamin C. Vitamin C, right? When the blood vessels start to crumble, they fall apart, they lead to bruising, they lead to bleeding, vessel rupture, we call it hemorrhage. Throughout the body, teeth will become loose, they may fall out, gums will bleed, connective tissues that hold the teeth begin to erode. Organs that were once held firmly together because of the connective tissue, dependent again on collagen, are going to lose their structural ability to stick together, their strength, and they're going to begin to fail. And in time, the different tissues of the body are going to start to fail and give way, and the endothelial lining of the cell is one of those tissues that starts to fail. So what does all this mean? Well, in 1985, a bunch of researchers got together and they verified that plaque will only form in areas of the artery that become damaged. Shall I say that again? Plaque will only form in areas of the artery that become damaged. So again, let's ask, why are they becoming damaged? Well, now we're looking at the underlying problem. This is what science has been showing us. Just like cracks might form in a garden hose that has become weak or overused from constant bending and high pressure, well, cracks from the inner lining of your arterial wall, the same thing. As these tiny microvascular cracks open up, they're going to expose little tiny strands of an amino acid called lysine. Lysine, which is one of the primary components of collagen, to the bloodstream. It's these strands of lysine that LPA attach to. Lysine. Stick out, LPA come and attach. So that won't happen unless there's a damage to the vessel wall. Okay, so collagen again is required for quite a few things. And vitamin C, along with other amino acids like proline and lysine. Linus Pauling believed if you give lysine, for example, the LPA will attach to the lysine that's in the blood, not to the lysine that's on the endothelial lining of the cell. And again, vitamin C, lysine, proline are absolutely essential for the formation of healthy collagen, which is and means healthy artery walls, clearly. This is just an image to sort of show you sugars, vitamin C, they go in through translation, all of this happens, an assembly forms, the cleavage happens, mature collagen assembles, and ultimately we end up having collagen fiber. But for this collagen fiber to develop, we need to have certain nutrients. And vitamin C or sorbic acid was that classical one where James Lind on a Navy ship gave them lemons and their scurvy went away. Well, nowadays, unfortunately, when you look at the RDA of what vitamin C should be taking, I think it's like 80 or 90 for an adult. That's just really trying to make sure and prevent you from getting scurvy. That is by no means the upper limit of what we should be taking of vitamin C. And I just put some names in here in case you ever want to go back and look at them. Although Dr. Gary Gordon is more about chelation therapy, the others really go into oxygen, and Mark Levine had some pretty impressive research done. Thomas Levy wrote a few books. Susan Humphrey has some nice talks on YouTube. Look them up if you're at all interested and you want to look at it. All right. Again, this is just to show you that, let's not get into this right now, but basically you understand that the current levels of vitamin D really are just trying to prevent you from getting scurvy, but they're not trying to promote optimal health. And that's a big problem. Now I'm going to rush through this really quickly because there's a lot. Each one of these, I'm going to go into them, and each one of these has 2 or 3 slides. So I'll let you, at your own discretion, go in and take a look at that. But these are the things that we can be telling our patients. Try to remove toxin, try to improve the elimination of toxins, increase fiber intake with water, improve your gut, healthy bacteria, phytochemicals, boost detoxification. What are some basic supplements for detoxifications? I'll show you additional supplements, right, that we'll talk about. So probiotics like lactobacillus and bifidobacter species can help normalize the gut flora. And that's really good because that reduces endotoxins, right? Toxins that are produced by an imbalance of the gut bacteria. So that's a really important one. So from a healthcare professional, this is going to show you what we are able to do right now. We can test for toxins. We can test for genetic detoxification. We can test for glutathione, superoxidase dismutase, or SOD. We can now already test for heavy metals, which we know are linked to high blood pressure, right? And high blood pressure is pressure up against an arterial wall that may already be weak. There you got it. See, right? We can look at red blood cell. We can do hair analysis. We can do chelation. There's a lot of questions about chelation therapy, but Dr. Gary Gordon and quite a few other people are already bringing the forefront about how it's actually used in many positive ways. We can look at urinary organic acids. We can look at sulfates and orotate. We can look at detoxification pathways. We can absolutely do all of this. We can test for chemical antibodies. We can look at mold, mycotoxin. We can look at IgG. We can look at celiac. We can look at digestive stool analysis for leaky gut syndrome, also known as dysbiosis. We can check for H. pylori. We can check for Lyme. So when you think of angina, there are so many other things upstream, outpatient, not in the acute care setting, not in the critical care setting. Again, if a patient has 220 over 180 blood pressure, we don't care about any of these toxin removals. We need to save their life. But when they walk out of the hospital, we can talk to them that they should be eating full organic whole foods, animal products, minimize them, but try to make sure if you do, no pesticides, no herbicides, no antibiotics, no hormones. Try to drink reversed osmosis or any type of filtered water to get rid of what they're putting in it. Use filters, ionizers, help dust, molds, a lot of allergic reactions. Clean and monitor heating systems to make sure that carbon monoxide are not being released. Right? These are just some really basic things. Try to get the house plants that can help filter your air. So when somebody tells you that, hey, here's your beta blocker, watch your heart rate. Here's your cardium challenge blocker. You just make sure you don't take it with, and see you later. We really haven't done a good job of telling them that there's a lot of things that, we can do with the patients. Minimize electromagnetic frequency radios, use of heavy metal exposure, eating certain types of fish, right? Try to help them eliminate their toxins. Make sure they take the fiber. Make sure they have 1 or 2 bowel movements a day. Drink a good amount of water. Sweat regularly. Steam baths or saunas, especially infrared saunas. Now there's a lot of evidence out there saying infrared saunas are fabulous. Tell them to go exercise their body, get yoga, meditate, lymphatic massage, which helps move the tissues out of the body. Allopathic medicine doesn't even recognize the lymph system and what it yet does and its ability to remove toxins from the body. It doesn't. If you have cancer, they'll remove the lymph nodes if that's what they feel is done, rather than try to boost upstream. Try to eat at least 1 cup of cruciferous vegetables every day, right? Phytochemicals. Garlic, decaffeinated green tea, juice vegetables. Try to consume burdock root, dandelion rind. Dandelion rind is wonderful. And the rest of these are as well. Eat high-quality sulfur-containing proteins with onions, for example. Eggs, whey protein, garlic, and onion. Eggs help with cholesterol. Cholesterol is not the enemy. Cholesterol helps build hormones in your body. We need it. Consume a lot of the bioflavonoids, cruciferous vegetables, cabbage, broccoli, collards. Consume dandelion greens to help with the liver toxic, help the flow of bile, increase urine flow. Increase, again, phytochemicals, celery, cilantro, rosemary, turmeric and curry, burdock root. Consume chlorophyll and dark leafy vegetables, right? Watch out with the bleeding. Yeah, we need to watch out with that, like a lot of the fish oils as well. So what are the basic things we need to do for the supplements for or foods? Take a high potency multivitamin, multimineral, both multivitamin, multimineral. Everybody talks about multimineral. They forget the multivitamin, but they forget the multimineral. Patients should be taking multivitamin and a multivitamin. Of course, if they have a lot of complications, renal failure and all of those, it gets a little bit more complicated than that. We're talking about a general healthy person who had some angina right now, and we want to make sure that, hey, look, we already can tell you what the underlying cause is because you guys already know what the underlying cause is, but take extra buffered vitamin C. And you can take a lot more than that. Milk thistle helps. to detox the liver, and essential fatty acids have the EPA and the DHA, which also have a natural way to help to thin the blood as well. Carnitine, I'll let you read this on your own. There's been significant effects to show that it can reduce triglycerides in the bloodstream and therefore helps improve the health of the arteries, right? The health of the arteries. How about we talk about the health of the arteries? Arginine, what used to be called Institute of Medicine, now called National Academy of Sciences, showed that L-arginine can possibly help progression with atherosclerosis, help decrease the possibility of the buildup of atherosclerosis, especially when taken with L-citrulline. So it appears that a combination of nutrients encourages relaxation of the blood vessel, which helps improve blood flow. Now, people, isn't that what we talked about as a therapeutic goal for a beta blocker, for a calcium channel blocker, for a nitroglycerin? I'm giving you tools here. There's tools like this that are, there's so many pieces of information. Citrulline, we just talked about, same thing, improves blood flow. And I'm going to let you go through this on your own. I just put in a Linus Pauling therapy for reversal of heart disease. So I'll let you go over this on your own. I'm not going to even talk at this point. Just do understand, if you want, as you go back, you can pause and write this down or print it out. I'll put a PDF file upload. Remember, when we're talking about angina, which is what this lecture is about, we're talking about atherosclerosis, which is what plaque buildup is, but we know now that underlying the plaque, there's arterial injury. Well, why is there arterial injury? Well, we know that the three finite inflammation, oxidative stress, and autoimmune reactions are one of the problems that lead to a lot of the breakdown and the weakening of the arterial lining. But now I'm giving you tools like L-lysine, CoQ10 enzyme, L-carnitine, magnesium. I cannot overemphasize the importance of magnesium. Niacin as well. Monitor with your liver a little bit. Got to watch out. Flushes as well. I'll let you pause this at your own time if you want. Vitamin E is a very powerful antioxidant. Works very well in combination with vitamin C. Is also a mild anticoagulant. So go figure, right? Helps produce collagen fibers. People, if we know that vitamin C, we don't make it. If we don't consume it, we don't have any. But you have to have vitamin C and a lot of these amino acids, including E, to build collagen fibers. So if we're not taking C or E or these amino acids, are you able to build collagen fibers? No. Period. You can't. You can't. You have to have the building blocks. Again, K2 is a very wonderful thing to keep calcium in the bones, great for osteoporosis as well. A lot of the vitamin D3 now on Amazon or one of the supplement stores, you can get D3 and K2 together. Again, watch out with K because it has some blood thinning reactions, so in certain patients we have to be careful with. And again, they can go talk to a provider about these things, but to a provider that knows what they're talking about and knows what they're using, please. Again, all approaches are needed. Drugs are not bad. Pharmaceuticals are not bad. I have seen them save lives. And in the acute and critical care setting, I could care less about broccoli or berries. I want those drugs, and I want them soon. So every approach is needed. In the right setting, the right approach. But I have a feeling that, still in primary care practice, the approach to the problem is not the one on the above level. We're still being treated in the outpatient, chronic care, primary care, upstream setting. You're still going to get a metformin for your diabetes. You're still going to get metoprolol for your blood pressure. And really what needs to start slowly happening is patients need to be told and informed, right? Informed of the need of what tools they can use. And you guys have all the tools right here. So we got to the final slide right here. This is it. There's no more. So when your patient goes home, what are you going to tell them? You're going to tell them about nitroglycerin, what they need to know. You're going to tell them about the calcium channel blockers and the beta blockers, what they need to know. Beta blockers don't give if the heart rate's below 60. Nitroglycerin, tell them how to take it, how many times they need to take it, 5 minutes in between. Make sure they don't touch it under the tongue, right? Tell them about whopping headaches. Tell them about that stinging sensation, perhaps, not always, right? What are we going to tell them about calcium channel blockers? We're going to go over those 3 medications, but we're also going to tell them when you leave here, if you continue doing whatever you did before coming in, I will see you again shortly, in a year, 2 years' time. You'll probably end up getting another angina, maybe an MI, maybe even a stent placed, maybe even a coronary artery bypass graft, cabbage as we call it. So we need to tell the patient, if you keep damaging your artery walls over and over again with the same insults, improper lifestyle, lack of oxygenation, not getting the building blocks into your body through proper phytonutrients, phytochemicals, the body is going to recognize that lack of all of those, not having vitamin C and E and the amino acids is an insult. Not having vitamin C and E basically does not allow your blood vessels to build up properly and have elastin and collagen. And so that's a chronic dysregulation that your body's going to notice, and it's going to start building a lot of the plaque. So the body, when it builds plaque, is doing what it's supposed to be doing. Plaque is, again, it's not the bad thing. In the process of trying to defend the artery from bleeding, from damage, the patient is becoming victim. The plaque is not the problem. The stent is not the solution. It helps when they're in an acute or critical care setting, absolutely, right? But once the receptors are stimulated, they end up with the same three finite responses that we had with blood pressure and dyslipidemia. We talked about that in those lectures: inflammation, oxidative stress, immune dysfunction. So that's it. When you go and do your first discharge patient with your patient, if they are there for angina, you will be probably better prepared than many of the other nurses, unless those nurses have been paying attention to really what the underlying cause of angina is. And this lecture was talking about angina. So we know what drugs are good, what drugs we're going to be giving in the hospital, and what we're going to watch out for, what drips we're going to be giving, what we need to watch out for, right? We know that, but we also know what we're going to do upstream, what we can do, what we can tell our patients to do outpatients. There's tremendous amount of things we can do, tremendous amount of information out there, and the patient needs to be informed. We can't just keep telling them that, hey, we took care of the plaque, see you later, go home, do what you were doing, because they'll be back again. And we don't want that to happen. That would be negligence on our part. And as healthcare professionals, nurses, again, registered nurses are healthcare professionals. I think that it is our duty, really it is our duty, to know this type of information and to pass it on to our patients. That said, you guys have a good rest of the day, morning, evening, depending on when you are listening to this.